we have Dr. William Davies, who is the author of DBT Essentials, the APT's 3-day course on dialectical behaviour therapy. Also, running DBT skills development groups, the APT's DBT Masterclass. He's the academic director and chief executive of the Association for Psychological Therapies. And if you want to read up about him, have a look at Wikipedia under William Davies, psychologist.
Lovely. Well, thank you, Amy, very much. So it always strikes me as slightly ironic, really, that dialectical behaviour therapy, the idea of a dialectic is there's two kind of opposing ideas which kind of join together and they're both true. And it seems to me with DBT, it's kind of one of the most cutting edge, advanced sort of therapies we can do. And at the same time, it's sort of quite reassuringly traditional. So I think if you were to ask a random group of therapists, what's the most cutting edge, most advanced, most evidence-based therapy, DBT would come pretty near the top of the list. But at its heart, it is simply, if you like, teaching patients the skills they need to know to lead a rewarding life and helping them apply those skills in their actual lives. And to a degree, although that's a big thing to do, it is at heart, it's that simple, if you like. So the plan for the session is to have an overview of DBT, which I found really difficult, to be honest. I've tried to condense a 3-day course into 35 minutes, I think, and it is tricky. So, but anyway, got an overview of DBT. I've done my best. And then what implications does DBT have for working with the COVID crisis, and in particular beyond the COVID crisis, or while COVID is still around but no longer a crisis? So let's have a look.
It was founded, if you like, in 1993 when Marsha Linehan wrote 2 books, Cognitive Behavioural Treatment for Borderline Personality Disorder. That's not a typo, it is CBT, Cognitive Behavioural Treatment. And there was a companion volume called Skills Training Manual for Treating Borderline Personality Disorder. And it was those 2 books that introduced what we now know as DBT. By the way, the Skills Training Manual, that is for, the skills are for the patients, not the therapists. It's the skills for the patients. So that volume 2 there, that is as the manual for teaching patients to the skills they need to know. And the great thing about that manual is it's got loads of photocopyable handouts, information sheets for patients. It's a fantastic manual for anybody involved in therapy, whether doing DBT or not. So let's have a look at Linehan's Biosocial Model. And she is kind of noted for the biosocial model of borderline personality disorder. Remember what we're talking about with borderline personality disorder. It is a very severe personality disorder. It's called borderline because originally it was thought to be on the borderline of psychosis. It's that severe. Characterized by impulsive behavior, suicide attempts, and indeed suicide. So this is seen primarily as a dysfunction of the emotion regulation system, inherited dysfunction. So we have biological irregularities combined with environmental stresses such as an invalidating environment, an upbringing which is invalidating, and especially invalidating families, chaotic families, perfect, too perfect families, and indeed typical families. So it's a two-pronged attack, if you like, that a person starts off with biological irregularities, and that's compounded by the upbringing. Linehan says that those 2 factors, the biological irregularities and the invalidating environment, both together mean that the child probably can't label and regulate their arousal in any meaningful way, and they can't tolerate emotional distress, and so on. And of course, she highlights that of the biological and family or environmental factors, maybe we can't do much about the biological ones, but we can look at the environmental ones. As adults, the person we're talking about with borderline personality disorder will probably be unable to validate their own emotional experiences, maybe unable to solve problems, maybe unable to reward or nurture themselves, hate themselves too when they fail to achieve goals, and are ashamed of being emotionally vulnerable. So it's a pretty disastrous combination of things, which people often refer to as borderline personality disorder. Now, this all means that when we see a patient, we have to be very good at validating. We have to almost compensate for the invalidating environment we're hypothesizing from earlier on. So Linehan looks at different ways of validating, and there's several which he lists. The number one is listening in an accepting and non-judging way, kind of unsurprised, which overlaps with the second one, reflecting back what is said in an unsurprised way. Number three, articulating thoughts and feelings that the patient has, the patient possesses, but hasn't actually said. Maybe because they're too ashamed to say those things, and to hear it from the therapist is very encouraging, because it's kind of that valid, that unsurprising that the therapist can actually say it, even though you, the patient, have not done. Number four is a nice one, explaining the patient's present by linking it back to the past, by kind of sort of explaining what the person feels and does, justifying it, if you like. And of course, overt validating statements like, anyone would do that in the same situation, or I would feel the same, so long as that's true, of course. Because validation is so important, I just want to spend a minute on it. And these are the fallacies, three big fallacies, wrong things that people think about validation. Number one, validating a person's emotions and behavior is like condoning them. No, it's not. It's just the reverse, in fact. If we validate the emotions and behavior from the patient, then the patient doesn't have to justify those things. They can move on with us, the pair of us. Number two, validating a person's emotions and behavior prevents them from moving on. And of course, just as we've said, it is exactly the reverse. It invites the question from the patient, okay, so my emotions and behavior are understandable and valid, but are they helpful? All these dreadful things I do and feel, they may be entirely understandable and valid, but they're not very nice and very helpful for me. And number three is almost the opposite side of the coin, the idea that validation by itself is a treatment strategy and will yield great results. No, not at all. It's not a therapy, it's a component of therapy, and it's also a component in everyday relationship building, a fantastic one, but not an end result on its own. And I suppose we should quickly look at the word dialectical. A dialectic is a discussion intended to resolve differences between two views and reach an agreed truth, almost the opposite of a debate. So it's a discussion aimed at resolving two apparently conflicting positions, such as your emotions and behavior are valid, and your emotions and behavior are not working well for you. And of course, you can see that probably, I guess, that both of those can be entirely true. Contrast with a debate where each of the protagonists is trying to prove the other one wrong and themselves right. So it's a simple idea. A lot is made of it, but it is a simple idea. A simple idea it may be, but it's a very good one. The real advantage of the concept of a dialectic is that it enables us to be clear that the patient's and emotions behavior are indeed valid. It's worthwhile just saying, actually, that it is the emotions and behavior. So a lot of people don't like validating unhelpful behavior, like attempted suicide and self-harm and so forth. They don't like doing that because it feels kind of wrong in a way. On the other hand, if you listen to people describing their situation, very often you can entirely see that what they've done and do habitually is extremely understandable and very valid, therefore. This is all important because in DBT it's hypothesized that the lack of validation during childhood especially is partly one of the causes of the patient's problems. So we have to compensate for that, if you like. So the idea of a dialectic gives us a strategy to address the patient's problematic behavior and emotions, while at the same time never implying to ourselves even that they are not valid. Now, this is a really important slide. It's about the modes of DBT. There's 4 modes. If anybody says how many modes are there in DBT, the answer is 4. And here they are. Number 1 is skills development groups. Now, these are the groups in which you teach the patients the skills that are going to be really useful and helpful for them, the skills they are lacking or weak on, and it takes a lot of teaching. Which means that it's going to be perhaps weekly sessions for a long time, maybe a year or so. Number 2, one-to-one therapy. That's for problem solving, overcoming motivational obstacles, and just keeping the person on track, really. Remember, we're teaching the person the skills they need, and we're helping them to apply those skills into real life. Number 3, telephone consultations, same thing, for generalizing learning, for crisis support, and if you like, in real life, coaching the person in real life, because the person is allowed to phone up and we're encouraged to phone up and say, I'm in this situation and the skills I've been learning, they're not, don't seem to be working somehow. And you, the therapist, have the chance of real in vivo coaching in real life. And fourthly, consultation team meetings for all the therapists and group leaders who are involved in DBT to get together to maintain their own motivation, check they're all sticking to the DBT model, to problem solve and enhance their own skills. So that's a fantastic package. And I think the great thing that Linehan did in DBT is to put together things which are, and to be honest, they're not, she didn't really invent these things. These were here to begin with, but it's a very, very good package, very well thought through, and all the kind of legs of it fit together and support each other there. And there's the 4 modes, and that's how it is. And the end result of this is that the UK's NICE, the National Institute for Health and Care Excellence, finds enough evidence to commend DBT for the treatment of BPD, self-harm, and binge eating disorder. Now, in fact, a lot of people regard DBT as a very well-worked variant of CBT, and the implication there, of course, is that you could think of it for almost any disorder that CBT would be appropriate for. It's well, if you like DBT, it's a wonderful thing. One of the best known concepts in DBT is the wise mind. If you think of the reasonable mind, that's the very logical way of thinking about things, full of reason. Almost too logical, maybe, at the expense of emotions and that kind of thing. The emotional mind, from the limbic system and so on, is thought of as the emotional way of seeing things, and possibly too emotional. Some people always say you must relentlessly go with your instincts. Well, they're great, but not maybe relentlessly. And the wise mind is thought to be the combination of the two, to produce something in the Goldilocks zone, not too hot, not too cold, not too logical, not too emotional, but just right. So that's a very well-known idea in DBT. The next thing that your one-to-one therapist will have is a relentlessly problem-solving approach. They'll be thinking in terms of solving problems all the while. Whatever you say as a patient, the therapist is busy there thinking, well, how can we get around this? How can we sort this out? So in DBT, problem solving is more than a technique. Problem solving is an excellent technique, I think. But in DBT, it's kind of more than a technique. It is an attitude of mind where we are always looking to solve problems rather than to elaborate them or, ponder them or anything like that. So it is a great skill to have, but we have the kind of problem solving frame of mind in DBT. Okay, so far we've been looking at the kind of overview of DBT, if you like, and what we do in the one-to-one sessions. But what about the skills development groups? These are, if you like, the key thing, a key idea in DBT, and they have to help people develop the skills, help patients to develop the skills that will benefit them, and it is one of the strongest pillars. There's a nice truism here, it's down the bottom. How can a patient do a behaviour if they are literally incapable of doing it? A person has to be capable of doing things before they can do them. So it's no use, in theory, it's no use us sitting in a one-to-one session with patients, urging them and motivating them and persuading them to do things they cannot do. No amount of encouragement is going to achieve that. So that's the idea. We have to ensure that they know how to do the things they need to do. So the groups in which we train the skills the patients need, skills training groups, are very important, and they have a predictable format. And here it is. 8 points. Number 1, we welcome the patients into the group. Number 2, we ask them how things have been since the last session, what's been going on, to get some feedback. Number 3, we have a mindfulness practice session. Number 4, we have a homework review, how they got on with homework. Then we take a break. Number 6, there's new teaching, a new skill, which implies new homework, so that's number 7. And number 8, we check out, and there we are. So 8 straightforward, logical, very good steps, and that's the agenda for a group. So patients can be in these groups, weekly sessions for a year. So whatever is covered in all that time. Number 1 is core mindfulness skills. It's amazing, isn't it, how many therapies we looked at ACT previously, and of course that has mindfulness as a key component. Core mindfulness skills. Number 2, interpersonal effectiveness skills. We know that interpersonal ability is very important in leading a rewarding life. So that's there. Number 3, emotional regulation skills, the skills necessary to regulate your emotions effectively. If we can't regulate our emotions, then we are in deep trouble. Distress tolerance skills, the skills necessary to tolerate distress. Everybody gets distressed, and we need to be able to tolerate it without something catastrophic happening. And finally, walking the middle path, not thinking or acting in extremes. The first area we look at is mindfulness, which features in a lot of therapies, quite rightly. So let's get on and look at it. My own feeling about mindfulness is one of the best things about it is that it deflects the second arrow, because very often it's the second arrow that is the fatal one, if you like. For example, if you take PTSD, it's bad enough if you have an exaggerated startle response. That is, I expect you know that part of PTSD, one of the frequent concomitants of PTSD is an exaggerated startle response. Any loud noise, even in a domestic situation, and you get this really painful surge goes through you. That's bad enough. But if every time that happens, you say to yourself, well, why did that horrible event, that trauma, have to happen, and why to me? I'm never going to be the same person, etc., etc. That is the second arrow, and it gets you into a spiral, going forever downwards. If you're prone to bouts of depression, if you get fed up and depressed about your bouts of depression, then that puts you straight into a very obvious spiral. The more depressed you get, the more fed up you get about being depressed, and so on. So the great thing about mindfulness is that it stands to get us out of that spiral by simply stopping the second arrow hitting, observing that you are depressed or startled or having PTSD or whatever, and stopping it there without judgment, without further judgment. So that is a terrifically powerful intervention from mindfulness, I think. The second area we look at is interpersonal effectiveness. So let's have a quick look at some of the acronyms we use there. So under interpersonal effectiveness comes the GIVE acronym, which people are very fond of. G standing for no attacks, no threats, no judging or sneering. It's a nice idea that we could sneer. I for interested. Actively listen to the other person, take an interest in their point of view. Validate. Show that you get their viewpoint with words and actions. Show that you understand what they're talking about with your words and your actions. And finally, E for an easy manner. Smile, be diplomatic, use humour if appropriate. Nice acronym, isn't it? Nice and short, easy to remember, and it even has E, which is a bit of sort of icing on the cake, I think, isn't it? But all very nice. And here's another good, simple, straightforward acronym from interpersonal effectiveness. Asking for things in particular, it's important to retain your self-respect. And here we go. Number one, be fair. Be fair to yourself, but also to the other person as well. The A stands for no apologies. No apologies. Don't apologize when you don't need to for asking for something or for being yourself. But make sure you do apologize when you need to. If you've done something, if you've done a wrong by somebody, then yes. But sorry to bother you with this request. No, it's perfectly entitled to make requests. Number three, stick to your values. Don't go against your values just to get what you want short term. Again, the shades of ACT there, aren't there? Act according to your values, to your principles. Stick to your values. And finally, truthful. Be truthful and honest. Don't pretend to be helpless just to get other people to do things for you. And there we are. There's a picture of Marsha Linehan. We won't actually see the videos. The video is longer than this talk. But there she is, Marsha Linehan. So the next one is emotion regulation, how to regulate your emotions. And the goals here are to be able to notice and describe emotions, giving them accurate names. We might think that's a very limited goal, but it is a valid one, a very useful one. To know the effect that emotions have on you, to reduce emotional vulnerability, and to have less unwanted emotions. We'll just have a look at a couple of the things that are suggested to achieve these noble goals. One is to get a balance in the bank, as they put it, by learning how to do pleasant activities, talking about regulating our emotions. So to have a list of activities you find pleasant, I think that's really important. Schedule activities into your day. Immerse yourself fully in the activity. Comes back to mindfulness. And again, apply mindfulness to enjoy that activity. Apply mindfulness so you don't think of things that would spoil the activity for you. And find activities that other people find pleasant so that you can do them together. The other side of the coin is having values and principles, again, shades of ACT, for example, to be part of your family or a family, anybody's family. Develop the ability to enjoy things and to relax, to develop those abilities. To make sure you learn new things. Some people think of learning things as kind of onerous, but not at all. It works well for us. Take responsibility for things. What's the slogan when you're bringing up children? Parents who take too much responsibility have children who take too little. Works whatever age. We need to take responsibility for a certain number of things. Take care of relationships, nurture them and foster them. Be true to yourself, have integrity, honesty, loyalty. So the next one is distress tolerance. So let's assume we are now regulating our emotions, but we do still need to be able to tolerate distress when that happens. Now, it's referred to as distress tolerance, as though we do nothing except tolerate the distress, and that's a great skill to have. But in doing that, it liberates us to actively address distress, to try to reduce it, in other words, or simply to tolerate it because now we can, and allow it to dissipate of its own accord. The first category of things that people look at is distraction techniques, which I guess most of us are pretty familiar with. So I just highlight one of them. It's the third one on the list. Create other emotions. And there's one there called sky jumping, jumping out of perfectly good aeroplanes with a parachute on. And it's a good example of that, I think, because if you take somebody who is lonely and they to go parachuting, if they've never been parachuting before, as they're jumping out of the aircraft, they're not actually lonely. That's not the predominant emotion that occurs to them. So it's a different emotion. It's not a question of being with people. There's no sort of relationships going on particularly, but it is fostering a different emotion which just competes with the other one. Self-soothing techniques get a lot of attention, quite rightly, at the moment, and you can Google them and find very good things. And Rebecca talked about this in last week's session on compassion-focused therapy. So Rebecca, for example, highlighted with an exercise, find your favorite place and focus on what it looks like. People watch, look at photos or photo magazines. Listen to music, use your favorite scent or baking coffee, eat your favorite food, take a bath, rock yourself gently, do some exercises. So it's great self-soothing techniques. This one gets even more attention. Tip, nice and short and very clear. So distress tolerance, it's unusual on the first one. You don't hear a lot about this. Temperature. Change your body temperature using cold water or ice. And this is literally what she advocates. Splashing yourself with cold water and ice. Number 2 is intense exercise. Walk quickly, run upstairs, jump up and down, run on the spot. Again, it's intense exercise. So it's a kind of shock to the system, rather like the temperature change. Third one's a little bit more gentle, paced breathing. Breathe in to the count of 5, hold, and then breathe out to the count of 7. We are less strong at breathing out than we are at breathing in, so that's why you don't spend so long breathing in. And finally, paired muscle relaxation. That's traditional sort of Jacobsonian type relaxation. Tense your muscles when breathing in and relax when breathing out. So that's a very neat one, I think. TIPP, tip skills, are pretty good, I think. And finally, we look at walking the middle path, because when we are distressed, we can react in extremes, either overreacting, as it were, or not reacting at all, probably for fear of overreacting. So under the heading of walking the middle path, we do look at dialectics, which is, if you like, the skill of understanding that two opposing things can both be true. And I think this is, we'll come back to it, I hope, but this is very true in the COVID crisis. There's a lot of opposing things which are all true. For example, in DBT, not the COVID crisis, life is difficult and it is also rewarding. Both those things are true. My parents don't let me do whatever I want, and they also care for me. Both true. My therapist keeps pushing me to do things I find difficult and also wants me to do well. So dialectics are those who kind of esoteric word. It's a very straightforward idea, really, but it's not an idea that a lot of people are used to. People like to have a simple truth, and yet you have two combined truths. We also tackle more helpful thinking patterns by tackling the traditional unhelpful thinking styles described by Beck in CBT, things like selective perception and jumping to conclusions and catastrophizing and so on. That comes under the heading of walking the middle path in DBT. Now, if you were wanting to take it further, in other words, to pursue the idea of teaching skills to your patients, DBT type skills or life skills really, you might want to run skills development groups to develop their skills, or you just might want to have handouts to help the individuals that you see. And there's various options. Number one, you get handouts from the web, DBT self-help, for example, and run the groups by trial and error. If you've got experience with running groups, that might be fine. Or if you're seeing people one-to-one, that works well too. Number two is there's two books. There's Marsha Linehan's book we mentioned earlier, and there's also a very good book by Rathus and Miller. Those are books of photocopyable handouts you can photocopy. And they also say how to run groups. So that's a pretty sort of solid option. To be honest, the book I would suggest is the Rathus and Miller book. If you Google that, get it from the web, you can have it tomorrow. That's a very good book, lovely handouts, better than anything you get on the web, I think, to be honest. So that probably is the front running option is number two. And we make a big point of not plugging anything on these Wednesday afternoon webinars, but it'd be stupid not to say we actually do run a 3-day course on running skills development groups. But that's enough said. Number two is a front runner and a very good option. So let's take a minute out to take stock. I'm a bit shocked because I found that trying to summarize 3 days or more in half an hour is difficult and you miss things out. So to those who know everything about DBT, I can only apologize. I know there's lots missing. Now, even so, let's take stock and see where a person could go from here. If you wanted to set up a DBT service, what you would do is to get typically pairs of people, at least one pair of people, to run skills development sessions where you teach people life skills, all the skills we talked about, like mindfulness, distress tolerance, etc. So you teach those over 12 months or whatever it would be. And you'd also see the same people as on the groups. You see them individually in one-to-one sessions. And you'd also support them in applying the skills they've learned in real life by telephone support. And all of you involved in the DBT service, whether running groups or running one-to-one sessions, you'd meet up in consultancy sessions. You'd consult with each other to support each other and check that you're doing everything as it should be done. And that sounds big, but it's also very kind of sensible. It follows on one thing from another. So you can do that. There's nothing impossible there. Equally though, a lot of people work on their own and are expected to work pretty much on their own. And you can build it into individual sessions. Once we've grasped that, in a sense, the key thing is to teach people the skills that they need to support them in applying those skills in real life and problem solving and validating and supporting them all the way through, there's no reason why that shouldn't be done in individual sessions. It can be made quite efficient too, because when we see people one-to-one, we will do a good assessment and know exactly what's required for that person to succeed. So we'll know exactly what skills they need. They don't have to go through every session of every skill. So we can pick and choose the very best tailor-made skills for that individual, teach them to them one-to-one, give them handouts from Rathers and Miller or from the web or from wherever, and support them in taking those skills off and improving their lives. So both of those methods is really good.
Ames, are you still there?
I'm here.
I'm getting anxious because you've normally cut in and asked things by now, or relayed questions from.
Well, I didn't like to disturb you, but we have got some lovely questions if you're ready.
I'm ready.
Okay. Somebody asks, what would you say to if you had a client saying that they've tried all the skills and nothing works?
And all the skills and nothing works. Well, they're probably right in that case. I find clients normally are correct. So what's two possible things going on there. One would be that we haven't been teaching the right skills, and it's other skills that they need. And that's one of the joys of working one-to-one. You can really tailor-make what the person wants. The other possibility, of course, is that it's not a skills deficit. Maybe it's a motivational deficit or whatever it is, in which case you want to focus on their motivation. So one or other of those two possibilities.
Brilliant. Siobhan says, does the peer aspect of the skills group hold real importance in the model? Lots of her clients say that the group work is a challenge for them and they often struggle to attend. Does it lose meaning if you're doing the skills work on one-to-one?
I think it's pros and cons for both. A lot of people who need help are very reluctant to go to groups. That's part and parcel of the problem, if you like. But at the same time, those people who do go to groups find that the other people there are, in a sense, just like they are. They might turn up to the group thinking that everybody there is going to be incredibly more advanced than they are, and they're going to be inadequate, etc., etc. But when they get there, they find there's a number of people, half a dozen people, or whatever it is, and they're all in the same boat, if you like. So that's a terrific advantage of going to a peer group. There's disadvantages as well, one of which was hinted at in your previous question, namely that it's a set number of skills, it's a set particular skills, and it may not be exactly what a particular patient needs, and it may be a lot of redundant skills they're learning. Having said that, though, these are very, very good skills. I think it's interesting for anybody, to be frank. They are excellent skills to be looking at.
And one more before I promise I'll let you carry on. Do the modes of DBT always happen simultaneously?
Well, yes, they do, because in a sense they are intertwined, aren't they? The person is learning their skills, and then they're coming into one-to-one sessions additionally in parallel to that, so that the one-to-one therapist can say, well, how's it going in the skills development groups? Are you learning the skills you need? Are you managing to apply them to real life? And at the same time as offering a phone-in facility to help them apply them to their real lives. So those three, if you like, of the four modes, those three in a sense are intertwined. Then the fourth one is the consultancy, where the people involved in DBT, they all get together and support each other, if you like. And that makes a lot of sense, because DBT is typically applied to patients who have significant problems. So the work is demanding. So it's only right that the therapists also get support, and they get checked that they check each other that they are doing things as they're meant to be doing, basically.
Brilliant. The questions and comments are coming in faster than I can read at the minute. So if you carry on, I'll keep on looking through them.
So see if I can get it going again.
Okay.
Right.
So if we look for relevant DBT concepts that are relevant to either reducing people's anxiety or helping them through things in a kind of positive way, then I think we find quite a lot. Let's have a look first at the first cluster of three. Validation seems to me to be like one of those things, whatever we're talking about, validation should be there to imply to people, to suggest to people, to say to people that their reactions are indeed valid, understandable, and usual, if you like. But what about telephone consultations and consultation team meetings? So we look at the first one first, telephone consultation. I was talking to Paul Gaffney, who did a presentation a couple of weeks ago here about rare events. And he's saying he's now part of a team that is monitoring people with COVID infections. And what he does is to phone them up. It's not stipulated that he must do that, but he does do, because it seems like the obvious thing to do, to phone them up and see how they're getting along. And it seems to me just a great thing. You can teach people all sorts of skills, but how they apply them in real life is the bottom line. And that's what he's doing. Consultation team meetings. Likewise, a consultation team where we all get together and check how we're doing, support each other, check we're doing things right and handling for the best. Especially relevant to new situations like what we're in now. There's no kind of established set-piece method for working with COVID-19 infection if you're in mental health. So to support each other and give each other ideas and so forth seems to me like a red-hot idea. Mindfulness skills and deflecting the second arrow, absolutely. It's stopping people getting into the spiral downwards. It's bad enough being anxious about things, and you start worrying about being anxious about things, that is much worse. Interpersonal effectiveness skills, I'm not so sure about that one, to be honest. It's obviously relevant for people everywhere all the time, but especially so in the COVID crisis, maybe not. Relentless problem solving, on the other hand, certainly is. This is a new situation for most people, us and everyone we're working with. So there are going to be new problems arising. So we need to have a problem solving mentality and to be good at doing it. Emotion regulation. Yep, this is a high emotion time, and it's going to continue to be a high emotion time for a while. And there's a lot of things we covered in that heading. But I think getting a balance in the bank is one of the top ones. Doing lots of things you actually enjoy. And that's one of the things that's almost glossed over or even argued against at the moment, where people enjoying themselves seems to be inappropriate, which I'm convinced it's not. Then there's distress tolerance skills, such as self-soothing and having values and principles. Now, this is probably, if we wanted to rank order them, this is surely one of the top ones, isn't it? These two distress tolerance skills. With a lot of people in a lot of distress at the moment, and to be able to tolerate, or there's a better word than tolerate, that's what is termed in DBT, distress tolerance skills, but there's surely better words than tolerating distress. It's kind of reacting to it and overcoming distress or neutralizing it or something like that, isn't it? And walking the middle path, well, that's what we're all striving to do, I guess. It's very easy to take quite extreme views about all sorts of things at the moment about COVID-19. And when you look at things that are going on worldwide, I think we've got an awful lot to learn about it yet. And I think it suits us well to be walking the middle path about it. It is very striking, isn't it? If you look at the worldwide incidents, it's Western Europe that has got it most badly. Italy, Spain, France, Belgium, Britain. We got it worse than anywhere in the world, really. Even countries that have responded, if you like, much less effectively than we have, haven't got it as badly as we have, because people say that other countries got bigger numbers infected, but they are bigger countries. So whichever way you look at it, we need to be walking the middle path. Okay, well, I think that serves as a pretty reasonable summary of everything we've covered, as well as highlighting the relevant concepts of DBT to the COVID crisis. So I'm going to leave it there.
Shall we have a little scattering of questions?
Okay.
Okay. Do you have to be trained in a core profession before being allowed to do DBT training?
Short answer is yes. Yeah, you have to be able to see patients, basically. and it's your core profession, psychology, nursing, psychiatry, OT, social work, probation, whatever it is, that's what entitles you to see patients. And once you have your core profession, then you are expected to keep up with the latest methods, and DBT is exactly that.
Could you expand a bit on the consult? Who is it for, and how should it work effectively?
Yeah, it's for the idea is that people are working separately. So there might be some people running the skills development groups. Well, there will be some people running the skills development groups, and there'll be other people doing one-to-one sessions, and they'll be different people, and they're all doing demanding work. So they go to a consult group to support each other, to verify that they are sticking to DBT principles, to check whether anybody's burning out with any particular clients, and also to share good practice. So if there's some patients who are doing really well, and it's good to share what's happening there, then that's what happens. And it's run in a variety of ways, to be fair, but a lot of importance is attached to it. So that if you're in DBT, if you're working in DBT, you pretty much sign up to be going to the consult meeting every week or every fortnight or whenever it's scheduled for, without fail. You're going to need a really good excuse not to go. And the agenda of the meeting is quite well laid out too. There's a chair, there's a note taker, and so on. And you go through a sort of a fairly typical agenda. You know, what's been going on since last time. Did the decisions we took last time, have they been implemented? Is there anybody who's getting to such a state working with a patient where they feel like giving up with that patient? Is there anyone who's getting to such a state working with DBT that they feel like giving up on DBT? And so on. Well, there's not much so on after that. That's pretty much it.
Brilliant. Sorry, one last one. I always get so nervous asking you questions because you have no idea what's coming, but you're always up to the job. Here we go. Working in offender care with the prisoners in lockdown means getting a balance in the bank can be very difficult due to the regime they're in. Any ideas to help with these? Very welcome.
Well, that is tricky, isn't it? But there's a very well-known book called Life by a chap who gave himself the pen name Zeno, and that was a person serving a life sentence in prison. And what he did was the book's all about his life in prison, and it's very gripping actually, because he has proper relationships. Just because other people are also in prison, it doesn't mean they don't all have relationships with each other. Proper relationships, proper education classes, gets involved with reading and listening to the radio and so on. And he has a very, very kind of a life that he's very stimulated by. And the last chapter of the book is where he comes out of prison. He's discharged after his life sentence, after about 15 years or so. And he comes out and he misses the life he had in prison. So, and kind of so does the reader. We miss the characters he knew and all the things that were going on in prison. So, you know, the reader kind of shares what happened to him. So it's not a blow-by-blow account of what you can do in prison. I worked in prisons for 11 years, and it is incredible what can go on there. But at the same time, I suppose what it demonstrates is that it's amazing how people do construct a very good life for themselves in prison sometimes.
Brilliant. Great. That's there's lots coming in, but we'll carry on. I've just seen the time.
Okay. Well, yes. Okay. I'll just finish off quickly then. I suppose this is, postscript and skills for the crisis. I'm very struck. I mean, I don't want to be like one of these people in the newspapers who always has a better idea than the government and all the best advisors in the world. But it is very striking comparing Japan with Western European countries. Because surprisingly, and this is uniformly recognized, that Japan's measures, the measures they've taken, have not been nearly as good as those of Italy, Spain, France, Belgium, or the UK. They've been late, they've been disorganized, they've been haphazard, they've been very poor in their measures. And yet, those same Western European countries had about 50 to 100 times more deaths per million population. So clearly there's something going on we don't understand. We think we do, but we just don't understand quite what's going on. And maybe what's going on is something parallel to Linehan's biosocial model. Partly genetic factors at play, partly societal factors at play, where people in Japan, who knows, maybe they keep a bigger social distance from each other kind of naturally as part of their society. I have no idea. I'm not sure that anybody else does either. But there might be something parallel, partly genetic, partly societal going on. And eventually we will learn what's going on with this virus, I guess. Which brings us back to the basis of DBT, which is to learn skills to equip us to the situation. So once we know what those skills necessary for living with COVID are, then we can learn them. The whole DBT model kind of applies very nicely, I think. We know what the skills are, people learn them, and on we go. Because I'm guessing that countries are going to have to learn to live with this virus unless somebody wonderfully produces a vaccine for it, which they might well do, but I'm very struck that there still isn't a vaccine for HIV, and that's been around for a very long time. But on the other hand, on a more positive note, there's lots of people saying they're on the verge of producing a vaccine. So, who knows? Right, that's it.